Dr. Kerrigan McCarthy. She's a consultant pathologist, Division of Public Health Surveillance Response at the National Institute for Communicable Diseases, the NICD. So we can ask her the questions that we want to. What we don't know is that she's also got an MPhil in theology, and she's a PhD candidate at Wits School of Public Health, which was submitted in September 2019. As head of Outbreak Response Unit, she has been responsible for the development of the Emergency Operations Center for the Management of Outbreaks of Diseases of Public Health Importance, i.e. the relocation of the former Life Esidimeni patients and the joint WHO South African Listeriosis Incident Management Team. Responsibility embraced together with respective team leads the development of notifiable medical conditions surveillance systems, support of the provincial epidemiological teams, Germs SA Laboratory Surveillance Network. Kerrigan, thank you for coming to us and helping us to understand how we're going to protect ourselves and what the surveillance systems are. Thank you.
Thank you, Margot, for the introduction. It's lovely to be in touch with Margot again. I worked with her on many TB projects for the years that I was working in the tuberculosis field. So you've had two very comprehensive lectures this morning on coronavirus from two very well-respected colleagues. And now it falls to me to share with you what the public health authorities are doing. And I want to say at the outset that you will appreciate that this is a very rapidly evolving field. This organism was only discovered maybe late December, early January, sequenced the end of January, and the epidemiology has been progressively unfolding as the case numbers have increased. And by its very nature, because of the uncertainty, there are going to be many different approaches to this condition. And I want to say that we here in South Africa are not alone in having measures of uncertainty around how to respond and how to react. So I'm going to share with you what we have done in the NICD together with the National Department of Health. And then I will also share with you a little bit about the global context around what is happening outside of our borders. So I'm not sure if you've seen something like this this morning. If I have, forgive me and bear with me. What I have shown you here is taken from the World Health Organization pandemic preparedness area on their webpage that deals specifically with swine flu and well, they called it swine flu, but with pandemic influenza and the preparedness activities around pandemic influenza. So it's not particularly helpful or it's not specific to coronavirus, but it is helpful for us in understanding why the global health community and us in South Africa are taking the stance that we are. It also paves the way for understanding a change, a potential change of strategy going forward. So let me explain. So the phases of a pandemic can be described like this. Phase 1 is when an organism that occurs in an animal context, so in other words, one that infects animals, is exclusively found in animals alone. Phase 2, there may be some crossover of this infection into humans, but it's a dead-end infection. Phase 3 is when there is repeated exposure or crossing of the infection into humans, and there may be some evidence for transmission from one person to another, but it's not sustained. Phase 4 occurs when this particular organism can cross the species barrier from animals to humans, and humans who are infected can spread the condition to other humans, and that transmission is sustained. After that, things get a little more alarming. So phase 4 is when there's verified human-to-human transmission. Phase 5 occurs, and this, remember, is an artificial definition by the World Health Organization, is that there may be spread of the disease between humans, and it's occurring in more than one country, but still within the same WHO region. And phase 6 is when there's community-level outbreaks in at least one additional country in a different WHO region from phase 5. And at this point is when the WHO should declare that there is a global pandemic. With the evolution of infections and pandemics, there will obviously be a post-peak period and then a post-pandemic period. So a few weeks ago, and let me also share with you the reason for this phased approach, or this breaking down of a pandemic into phases, is because it helps us understand what are the appropriate responses in the different phases of an outbreak. So in phase 4, when there is human-to-human transmission and the virus is able to sustain a community-level outbreak, it is critically important to direct and coordinate rapid pandemic containment activities to limit or delay the spread of infection. Okay. In phase 5, where there is sustained community-level transmission in 2 or more countries in one WHO region, or phase 6, when there are at least 2 WHO regions affected, the appropriate response changes to providing leadership and coordination and to multi-sectoral resources to mitigate the societal and economic implications of the condition. So you'll appreciate from this that a few weeks ago, there's absolutely no doubt we were in phase 4. There was sustained human-to-human transmission in Wuhan, and following the New Year celebrations and the dispersal of more than 5 million people from Wuhan back to different areas of China, that there was sustained community-level transmission, but within China only. And there were sporadic cases, exported cases into different countries that had received travelers from China. And when the WHO derived their responses, this was the thinking behind the responses. It was primarily directed at containment. And the thinking behind that is that if you have the disease localized to a certain space, you want to keep it there. And if you don't have the disease yourself as a country, you want to be able to detect, identify, and contain cases so that they do not spread from person to person. And so as a consequence, activity should be directed at early detection and containment of the responses, containment of the infection to certain very discrete locations, like preferably a given hospital or so. So the timeline of our outbreak has gone exceedingly quickly. The 31st of December, China sent alerts to the World Health Organization, closed down the seafood market in January. On the 7th of January, the new virus was identified. On the 11th of January, they announced their first death. On the 23rd of January, Wuhan was placed under quarantine. On the 30th of January, the World Health Organization declared this as a public health emergency of international concern, and we're way down the way from the 2nd of February when the first international death occurred. But if we look at the timeline of events of how we reacted as South Africans, on the 24th of January, we called our multi-sectoral national outbreak response team, that's M0, which is a regular standing committee that meets once a month to receive feedback from a multi-sectoral stakeholders across the public, private sector, civil aviation, port health, environmental health, hospitals, security, around health matters. So we convened a meeting around about the 24th of January and started developing a response or through trying to understand what the risks were to our own country. Then, on the 30th of January, our health minister declared a public health emergency in South Africa and activated our emergency operations center. And then on the 31st of January, we commenced with daily incident management team meetings, which have been ongoing. So we have been working flat out since our own declaration of a public health emergency to work together to coordinate resources and activities to make our country safe. So, where has that left us and what did we do? Well, we learned a lot about outbreak investigation and management during the Listeria outbreak and also during the Life Acidemene crisis. The world currently uses what's called an incident management system that operates from an emergency operations center. And the incident management system is basically a modular way of addressing a disaster, where one identifies certain key tracks or areas within a response and assigns team leads, and then allows people to take initiative and to follow through on specific planned activities in their area of responsibility. So the key way that an incident management system works is through working to provide objectives and sub-objectives and activities to support the objectives through the creation of an incident response plan. So because we hit the ground running, we started with many of our activities before we formulated our plan, but we identified certain key areas where services were important. So the first was epidemiology and surveillance, starting from the left at the top. So there, of course, is the critical response for early detection of cases and tracking of cases and context should we have cases. Case management and infection prevention control is an important area that we identified, as well as facility readiness. Communication cannot be underrated as an important component of preparing both community and healthcare workers to receive the cases and to better understand and manage cases. Laboratory diagnostics are a critical component of early diagnosis. Ports of entry were critical given that we, like most countries in the world, prepared to accept or realize that our threats lay outside of our borders and that people coming across borders are going to bring the disease with them. Emergency medical services also very important. There was some talk around evacuating our citizens from Wuhan, but obviously also if we do have suspected cases and they need to be transported, they need to be done so in a safe manner. And then we had a team that was responsible for management and coordination, and this includes human resources management, resources, and logistics. So I'm going to basically give you a snapshot overview of what we've done to date, and then contextualize that in the international, with the international developments so far. So with regard to epidemiology and surveillance, the first thing we did was we drew up some guidelines. We consulted obviously our international colleagues to see what had been done elsewhere. We made the guidelines very comprehensive. And of course, these are currently being updated because the field has moved since we published them in the first week of February. Very importantly, this guideline document not only contains important things like the case definition, but it also contains tools in the appendices for very important things that you may need to do yourself. So in addition to the case definition, there are also documents on definitions of a contact, who is a contact, and tools to support contact tracing. So because we have a containment approach, our initial cases that we have are going to be intensively followed up by teams of people in the provinces and districts, and they will do contact tracing. So it's important to know who are the contacts and how to monitor the contacts. So there are also tools that contacts can use to monitor themselves. So there's a 14-day checklist where contacts can monitor their symptoms along with details of who they should contact if they develop symptoms. So these guidelines may be found on the NICD website. You can access it two ways. You can land on the homepage, or you can go to Diseases A to Z and look under coronavirus. We also, the NICD has for years manned a 24-hour hotline, and we implemented this hotline to support case investigation for persons under investigation. So when Prof. Scholz talks about phoning the NICD, he phones these numbers. Those are the numbers there. And these persons are doctors, and they are very familiar with the case definition. If they are uncertain about something, they call one of the consultants or the laboratory pathologists, and we discuss the case together. So I can share with you our current case definition is a patient with acute respiratory infection, that is the sudden onset of at least one of the following: fever, cough, sore throat, shortness of breath requiring hospitalization or not. And very importantly, in the last 14 days prior to the onset of symptoms, they must have met at least one of the following epidemiological criteria. And these are either they were in close contact with a confirmed or probable case, or they had a history of travel to areas with presumed ongoing transmission, and we say presumed community transmission. And at the moment that is China, but if you are following the updates of cases, there are a number of other countries in the world where community transmission appears to be happening. Or they worked in or attended a healthcare facility where patients with COVID infections are being treated. So we are not going to test people who do not meet the case definition. So we've had lots of queries from people coming through Dubai and now have an upper respiratory tract infection, and they're worried that they may have this disease. So like I said, it's a rapidly evolving field. We cannot test everybody because we do not have resources to test everybody. And so we have to be very cautious about who we test. What is also interesting is that the transmission dynamics of this organism are not well known. And those of you who followed around the Diamond Princess will know that of the 460 odd people that they found to have this disease on the Diamond Princess, over half were asymptomatic. So they had a positive PCR on a nasopharyngeal swab or a sputum specimen, and they did not have symptoms. Now, what is not known about this disease is whether people who are asymptomatic can transmit infection, and also whether people who are asymptomatic go on to develop disease. And so we have made a decision along with the global community not to test asymptomatic people. Whether that's right or wrong, at this stage we don't know. We may change that. But this is what we are doing at the moment. Right, so regards our hotline, unfortunately I couldn't find the situation report, our internal situation report that spoke to our hotline, but the first weekend that we were up, we had over 155 calls to our hotline requesting advice for testing, but it has subsequently decreased. So on the 11th of February, we had a total of 50 calls. And last weekend, or yesterday, we had only 4 calls. So the function of the decreasing number of persons under investigation or meeting the case definition that we are aware of at the NICD is decreasing. And there are 2 reasons for that. The first is here in South Africa, the media hype has closed down in recent days, certainly towards the end of last week. But secondly, the volume of passengers from China has also decreased, because the public is now increasingly aware of the risks of traveling to China and is choosing either to defer or not to go. And the majority of airlines in the world have closed off their routes to China, making it more difficult for travelers to go. However, we are aware that South Africa has an enormous number of South African nationals working and living in China or studying in China, because the Chinese government has offered and continues to offer bursaries for people to study at tertiary education there. So and of course there are trade relations between our countries. So there will be a baseline number of people moving to and from China. What is interesting is that we chose to phrase our case definition, and let me go back to that slide, to say that the person must have a history of travel to areas with presumed ongoing community transmission. We did not say had a history of travel to China, because we anticipated that the areas with community transmission are going to increase. And in fact, even over the weekend, Iran has reported an enormous or surprisingly number of deaths. So they've reported 8 deaths and 43 cases. Now, the death rate across the world is 2% in hospitalized cases. And so this tells us that they are not finding their cases in Iran. And we know that Iran is in a state of social and economic turmoil, and a number of countries have chosen to close their borders to Iran. So all I'm illustrating is that this case definition is robust in the face of changing areas of the community outbreak. So as the community level outbreaks expand, our case definition will remain the same. I think, however, before we panic, we need to look at the risks. So, for example, Wuhan itself has a population of 60 million people. That's the same size as South Africa. And to date, they have 65,000 reported cases. it must still be possible to live in Wuhan and not know anyone who's had COVID disease, because the proportion of patients is 1 in 1,000 to 1 in 10,000. So that's very small. I remember the hype we had around the listeria outbreak, where there were only actually 1,200 patients in the country who had listeria. And there were, most people in South Africa did not know anyone who had listeriosis, but yet our social media was full of reports about listeriosis. So, in other words, when we talk about an area with community-level transmission, and we say, goodness me, South Korea now has an enormous number of cases, can we classify anyone who comes from South Korea now as being at risk for this condition? Well, we have to put it in context. What is the proportion of cases relative to the population in that country? What are the geographical areas that are likely or where transmission is taking place? And what were the risk behaviors of the person who has traveled? So it is important to hold reason in our head before we apply our gut reaction of fear of contagion. So that's really what I wanted to say about that. So very important, what we have also developed are tools, data collection tools for persons under investigation and contact tracing and reporting. So if, for example, you find a patient, a suspected patient who then becomes a case, in your facility we will need to do contact tracing. You will find the tools to do that in the guidelines on the website. And if we have few cases, so if you happen to have the index case, or case number 15, we'll still be intensively following up patients because we'll be in a containment mode. Someone from if you live in this area, from the city of Tshwane or Gauteng, will contact you and support you to do contact tracing and keep records of the contact tracing that you are doing for your patients. So moving on to case management. So this is the area where we have been developing guidelines for management of cases, which is really the treatment of severe acute respiratory illness, guidelines for quarantine, facility readiness checklists, and training material, including IPC. We also have been providing provincial training in epidemiology, surveillance, infection prevention and control, and facility readiness. We've been working very closely with the 11 designated facilities to support them as they prepare to receive patients. We've also been developing data collection tools and indicators for the cases because we want to track what happens to our patients in South Africa when this disease comes to us. We want to know what the natural history of disease is. We want to know what proportion of people require hospitalization. How do people recover? How does HIV alter the clinical and manifestation and natural history of our condition? So we want to be very sure to collect good data. And one of the lovely things about this outbreak, if there can be anything lovely about an outbreak, is that we've had time to prepare. So we have case data collection forms. So should you have a case, we will share these forms with you. In fact, you can already find them on the internet, on our website. You can download them, and we will be collecting data from them, from your patients that you look after, and we will ask you for regular daily updates. So there's a short little data collection tool, half a page, to collect every day until such time as the patient is discharged. We've also convened a group of expert infectious disease physicians to provide guidance to clinicians who manage these cases. So although the condition is a new virus, there's a lot of global experience around obviously the SARS virus, MERS virus, and the treatment of severe acute respiratory illness is rather generic in the sense that one has to provide supportive care regardless of the etiology, and one also has to manage patients' complications. And so we have a group of infectious disease physicians who are on call to support this. We also, very importantly, have developed guidance on the management of asymptomatic persons returning from areas where SARS-CoV is circulating in community. Now, this document will appear on the website either today or tomorrow. It's still under review by our National Department of Health, but we have consulted widely amongst physicians in the country and invited comment, and also looked at what's going on in the international community. Now, a lot of countries, including the United States, have decreed mandatory quarantine for 14 days for anybody returning from China. And one of the challenges in our country is that we do not have resources to enforce these kinds of behaviors in people. We cannot enforce the speed limit or driving without cell phones or the blood alcohol limit while driving a vehicle. And rather than adopt a mandatory quarantine approach for asymptomatic persons, we have adopted the approach that a person may return to activities of daily life, but ensure conscientious hand hygiene, given that the likely mode of transmission, dominant mode of transmission, you've heard a lot about droplet spread from Prof. Stolz, but the reality is he showed a nice slide showing that the droplets fall to the ground within if they're airborne, 12 hours. The bottom line is that they may last longer on a surface than they may last in the air. And therefore, direct or indirect contact may well be the dominant mode of transmission of this organism. And therefore, meticulous hand washing is critical in our implementation of infection prevention and control when advising people who return from areas where there's community transmission. These persons will also be obliged to self-monitor, and should they have any symptoms, does not matter how insignificant they are to self-isolate. So at that point, they need to stay away from other people, and we've defined that very clearly in the document what self-isolation means. And if they are supported by an institution, so for example, they're either students at a university or within a company that's decided to repatriate people, the company, we advise the company to provide support for the quarantine process, the self-monitoring process. So we are asking companies to enlist their occupational services, universities to enlist their campus health to support people during that 14-day period of return or after return from an area where there's community-led travel. If symptoms develop, that person should be treated according to our guidelines for symptomatic persons. That means they should be immediately put in isolation, they should have a specimen collected, and they should self-isolate until the result is available. If they are ill enough to be admitted, they need to be admitted into a facility, and preferably to one of the designated 11 facilities if it is public. If it is private, it needs to be admitted by arrangement or prior consultation with the facility manager and the hospital group, so that that private hospital group can assign an appropriate level of care. I also can say that one of the other activities we've done, in addition to having a core group of infectious diseases consultants, we also have a group of all the private hospitals are meeting every week, every Tuesday afternoon from 4 to 5 by teleconference to share updates, guidelines, procedures, pandemic preparedness plans, etc. So the private sector is fully on board and gearing themselves up to address these issues. Another aspect that we are dealing with is the aspect of facility readiness. So we have developed a facility readiness checklist from the World Health Organization sources, and we have established that this, we have distributed this checklist to private sector, to the public sector, to all levels of care. And we're in the process of supporting the district and provincial governments to ensure that it is completed by all levels of care. What is also happening is there are 2 additional plans that our facilities are developing. The first is a first 48 hours checklist or preparedness plan, and this really is for the provincial governments. So once we have a case, we want to know exactly what needs to be done within the first 48 hours after detection of a case. And secondly, pandemic preparedness plans to accommodate for a larger, more broad-scale outbreak. What is very important to note is that Prof. Starts talked about buying his own N95 masks and ordering them, and they haven't come yet. And the reason they haven't come is that you cannot buy N95 masks if you're in the public sector or in the private sector today. You cannot buy them. If you've got some, lock them up and use them appropriately, and use them in the best and most appropriate circumstances. Do not use them indiscriminately. And we are not alone in this circumstance. The entire world has a shortage of N95 masks for obvious reasons. I mean, the demand has exceeded supply. All three large hospital private groups have told us they cannot get these masks, and they also have been approached by rather nefarious groups to buy back their stock so that it can be sold at 10 to 100 times the price in China. So one has to be incredibly cautious about how and when one decides to use these equipments. Right, the next section that we've been working on is laboratory diagnosis. So our laboratory had set up the PCR based on the sequences that were published within the first 2 weeks after the sequences were published. We've subsequently obtained the Centers for Disease Control recommended methodology, and we've retested all our specimens. And we've also subsequently obtained a kit that was made available and distributed globally by Roche. The photograph you see there is the training course that happened last week. We're also glad to say one of the private labs has obtained one of these kits, if not all of the private labs, and we will be working with them, the NICD. We are already in collaboration to decide who should test. But the bottom line is, because we have the case definition that we do, we've had many inquiries for testing, but we only test those that meet the case definition or where there's a very cogent reason for doing so. And so of the inquiries that we've had, 76 have met the case definition. We've tested 69, and we haven't found any that are positive yet. So when Prof. Starts talked about patients, he meant patients in the sense of they're ill people. He didn't mean patients in the sense of they are confirmed positive cases. We have had no positive cases to date. Now, does that mean that we don't have the virus in our country? No, it does not mean that. Italy is a good case in point. So those of you who followed the news over the weekend will realize that Italy jumped from 3 cases on Friday to 160 this morning. And what happened was, in about 3 or 4 towns in northern Italy, for some reason they tested persons with severe pneumonia in ICU. And they identified clusters of cases, and then went back and found there was a possible link with someone who had traveled to China. But they're still trying to trace the exact cause. Now, one of the reasons why this may have happened in Italy and may well have happened in our own country is because the disease has an incubation period. It takes 12 hours to travel, or 12 or slightly more, maybe 18 hours to travel from Beijing or Shanghai to Johannesburg. The incubation period, as you saw, can range from 2 to 14 days, if not 23, although that's unlikely. And persons may be asymptomatic when they cross our borders. So although we've jacked up screening at Port Health, and I'll share with you a little bit more about that, people may not be symptomatic. Secondly, when people do become symptomatic and they've got the common cold, and they're not ill enough to seek healthcare, they won't seek healthcare. And so in those circumstances, they may facilitate onward transmission, but not be aware that they have the condition. And that being the case, we will only pick up that we have coronavirus in our country if we have a sufficient number of cases and if we have clusters of severe pneumonia and we test them. So that requires the broadening of our case definition. Now, the debate as to whether or not we should broaden our case definition is fierce. Hey? There are some people who say we should be broadening our case definition. We have fantastic surveillance systems for influenza. So we have what's called the Viral Watch, where we have GPs across South Africa. Some of you sitting in the audience may already be part of that. And every time the GPs meet someone with the case definition, they take a throat swab and they send it to us and we test for influenza. We could easily add coronavirus testing to that, and we may well pick up cases. But the transition to tests is, to change our case definition is critically important. We cannot just test surveillance specimens willy-nilly. So, for example, if a person goes to the GP and they're part of the viral watch, the GP will say, I'm taking your specimen to test for influenza. We can't just suddenly lump that person, oh, by the way, you gave a specimen for influenza, but you've tested positive for coronavirus, okay? So, in other words, we have to prepare the country and the community for a change in our case definition. And this requires some very careful, considered thought as to what the implications may be. The bottom line is, at the moment, we do not have clusters of unexplained pneumonia, and we do not have cases, confirmed cases of the disease. But that's not to say that that will change. It may change. And so we have to be on the ball in terms of how we coordinate ourselves and what we do. A very important part of outbreak management and response is communication. So convey consistent, trustworthy messaging around the presence of cases, around prevention, around interventions. And we're very grateful that at the moment the NICD has a very good reputation and people trust us. We're grateful not because it's a feather in our cap, but because it keeps our community safe if there can be a trusted voice. So if you're worried about anything, phone our media liaison officer, call, look on our website. Most certainly, there is trusted news sources there around cases and where we're investigating and what we're doing, what the country is doing. We also have opened a public hotline, and you can take this number down. The calls that phone are triaged, and should there be anything that needs escalating, there are appropriate ways of doing that. Obviously, we have media releases when this is appropriate. One of the important things we do is counteract fake news. So it's happened regularly now. There was on the weekend, there was a rumor going around that there were cases in K2, in Sishen, and the whole of the northern province was on lockdown. So it's very important that we nip those sorts of messages in the bud early, and we provide authoritative comment on them. Our protocol for screening of returned travelers via air and sea ports and land points is being strengthened. So we focused initially on the airports, and we then moved to the seaports and the land ports. The Civil Aviation Authority has conducted numerous trainings and simulation activities with the Airports Company of South Africa for simulated cases, and we've had a few dry runs where, near misses, where we can say, and I say it was a near miss because there were suspected patients identified and stopped at an airport, and our systems have been tested and tried. And every time we get a case that is negative, we sigh with relief, but we go back and we learn what can we do better this time, where were the problems. So one of the challenges you can imagine of a patient returning by air is that they came on a conveyance. They came on a ship or they came on an aircraft. And so contact tracing would include finding the details of the people who were sitting in the aircraft. And the international guidance has helped us that we only need to find the people who were sitting 2 rows in front and the people 2 rows behind. Because why? Because of the Wells-Riley equation that tells us that the length of time that someone is exposed is absolutely one of the important determinants in the risk of infection. And those people who were sitting for 12 hours in the same rows are very important. There's a lot of concern around air travel. Firstly, the ventilation systems in aircrafts are very efficient, but contrary to logic, they do not have an airflow that goes up and down the fuselage. They have an airflow that goes in parallel with the seats. And so therefore, people who are at risk are people who sat in the same row and not people along the length of the fuselage. So this is very helpful to console people who may feel worried or threatened. Right, very importantly, We've also been liaising very closely with emergency medical services and with NatJoint. So NatJoint is the National Joint Operations Committee. It's a police force chaired and managed committee that responds to security threats across the country. So they are in regular contact with us around suspected cases, around the developments in our space and in the global space that can help us enlist their support should we need it at a moment's notice. We also have a team that does coordination and planning, and one of this team's roles is to keep abreast of global developments. So how do we do this? There are a number of senior staff that participate in international forums on a weekly basis. So on Thursday afternoons, there's the Global Outbreak Response Network call, and on Wednesdays, there is the International Global Health Leaders call. So we split these calls amongst us, and at each of these calls, there's a feedback from each country. There's feedback from the World Health Organization around their developments, interventions, resources, for example, the clinical trials that are ongoing. We also are invited to comment on documents. There is also resources in these to advise us. So, for example, when our government was and is still considering bringing back or repatriating our citizens from the Diamond Princess or from Wuhan, we were able to get into contact with people who are facilitating this in other countries. So the Canadian Health Protection Agency has been very helpful, and we're having a conference call with them next week to understand how they did their repatriation, how they screened people, how they handled their quarantine orders. An area that I haven't spoken about, but which also falls into the coordination and planning, is the legislation in South Africa around enforced quarantine and mandatory medical examination. So all countries in the world have a piece of legislation like this, and some countries are less concerned about human rights, and others are more concerned about human rights. So in China, you can undergo enforced examination, and the authorities can do that at the drop of a hat. In South Africa, we can force people to comply with a quarantine order or to give us a specimen, but we have to, the head of department in the province has to motivate before a magistrate as to why this person poses a public health threat. And that is an immense undertaking. It means that the health department cannot lightly forcibly take specimens or forcibly quarantine someone, but we are setting in process motion so that this can be done and will be ready should it be required. So the magistrates, the civil justice departments have after-hours magistrates, the provincial health departments have legal advisors, so it can easily be done. There's no reason it won't stand in our way, in other words. We're also formulating a plan. As I said to you, our activities had to start before the development of the plan, so the plan is nearly in finalization. We've identified partners and funding. We're also supporting the continent. So a number of us are involved in laboratory training, development of case management materials for clinicians across the country. So all that being said, all of our activities have been founded on the premise that we want to contain this disease should it enter the shores of our country. Or if we find it's already here, we want to try and contain it and keep it in the space where we find it. But as Prof. Salt shared with you, it's going to be very difficult. Hey? So the wonderful resources that Steve Biko Academic Hospital has are not equaled. Perhaps Charlotte Maxeke in Johannesburg has, and perhaps Tygerberg and Grooterschuur, maybe Bloemfontein. But we cannot replicate these isolation facilities across the country in droves, in numbers. And there's a growing recognition globally that this is a problem. Secondly, an astute observer reported that the social consequences of a containment strategy, or let me rather rephrase it, the social consequences of this disease across the world, in other words, the economic downturn that China is facing, are a consequence of the containment strategy and not of the outbreak itself, at the moment, that is. Hey? Remember I said to you, 70,000 cases in Wuhan in a population of 60 million of which 80% have mild to moderate disease, but the economic cost is going to be trillions. And the question you have to ask as someone who's looking with a bird's eye view is, what is the cost benefit of this? And at what point do we say, this is a pandemic, this condition is going to cross the globe and not respect borders or economies? Is containment the best way to manage this condition? And so the World Health Organization is seriously considering transitioning to a mitigation strategy. Remember I showed you those slides in the beginning where they started off planning for containment in phase 4, but now we've definitely reached the criteria for stage 6. I think the declaration of a global pandemic is imminent. It may well happen this week. 156 cases in Italy from 3 separate geographical locations with no known connection to China. That's a second WHO region. So it's in the EMRO region, not the WIPRO region. So that tells us that we need to start having a different mindset about this condition. And this table over here that comes from a WHO document, and I have to say that it is not for circulation, please, at this stage, are the considerations that we need to think about in shifting from containment to mitigation or prevent and control. And there are a number of issues that we need to look at in terms of patterns that can help us understand when is the time to move and how to do so. The first is the transmission pattern of disease, and I've already described that when the transmission reaches sustained, when the transmission is sustained in multiple areas of the same country or countries in multiple areas, it is not then, that is one of the criteria that we may want to look at to help us move to a mitigation strategy. The second is around response capacity and healthcare resources. So if we have 15 cases in the country, we might well be able to hold our case, but already supply of PPE is not adequate. Already in South Africa, we know you won't be able to buy your N95 mask anywhere. So what are we going to do? We need to shift our resources to reduce the impact on populations or health systems. And we need to fast-track medical countermeasures. We need to investigate the use of non-pharmaceutical measures, both in treatment and prevention. When it comes to disease severity, it may happen, and many people who are sensible have said that this condition is very similar to that of seasonal influenza, albeit that the disease severity is higher. And the magnitude to which the disease severity is higher remains uncertain at this stage. And the reason for that is because we do not know the denominator of infection. We do not know how many people do not present to healthcare services, either in China or in any of the other areas where there has been transmission reported. It may well be that these people on the Diamond Princess can provide some of the answers. So over half the cases had positive PCR on their throat. We don't know whether they're going to go on to get illness. If they don't, it may well be that the infection is immunizing and that they had asymptomatic disease. That does two things to our understanding of the epidemiology. It makes us realize that the outbreak is unimaginably bigger than what we appreciate, but secondly, that it's also the proportion of people who get severe disease is much, much smaller. The last thing that I want to share with you is that there are social factors and country context factors that may help us make the decision to move to prevention and control. At the moment, the interventions that have been implemented in countries that are trying to contain the virus lead to the most terrible disruption of society. Okay? So people who work in China cannot go to work. Public transport in the big cities is stopped. People have been housebound for several years. Can you imagine the social implications of that in our country, where we have unemployment of 25%, and those people who work cannot go to work because there's no public transport and there's no effective income. Imagine if we avoid congregate settings. The people who have informal employment, who sell things on the side of the street, will not be able to do so. The social implications of a containment strategy in our context are perhaps worse, immeasurably worse, than the disease itself. Yeah, so really I hope I've left you with a feeling of the complexity of the decisions that and actions and responses that go into responding to an outbreak of this size and magnitude. And you'll appreciate that from my vantage point, there are criticisms to high heaven of the strategies that the government is taking or the government is not taking, but the bottom line is there are no answers. And collaborative discussion followed by decisive action in a given direction is the best we can do for the moment, given all the uncertainties that there are about this disease. We welcome and value unbelievably your support in your sphere of influence around the containment strategies at the moment, around case detection, if we do have cases, isolation and following up. And we value that people at the cold front of the disease are those most at risk of acquiring the disease. And so with that, I want to end my talk with appreciation for the work that you are doing as you interact with members of the public and with your colleagues around keeping our country safe from this disease. Thank you.